I titled my talk about harnessing the immune system in kidney cancer, the current and novel immunotherapeutic approaches. My talk will be focused mostly on the most common type of kidney cancer, clear cell renal cell carcinoma. Dr. Sowell, my colleague, later in this session, will speak about the variant or rare histologies or subtypes of kidney cancer. But clear cell constitutes about 75% or more of kidney cancer. And so therefore, there's really important disease. And we can learn from the common ones to apply this knowledge and research results, findings into the rare ones, and vice versa. We can learn from the rare ones to apply to the common ones. So since 1992 until the present time, the FDA has approved 17 agents or drugs or therapies. And those 17 therapies are here. And they fall into 5 categories, and you can see that here to the top upper corner of the slide. These are 5 slides, cytokines, and exemplified in the cytokines, the high-dose IL-2, which you heard Dr. Campbell speak about. We don't use it much anymore because obviously we have now, better therapies and that we can apply to more patients than high-dose IL-2, which was really restricted to a minority of patients who would qualify or would be eligible for it. But that's the cytokines. The next is VEGF-directed therapies, and exemplified here are many of these drugs that end with NIB, NIBs, INIBs, and those are the oral agents that target VEGF, and VEGF is vascular endothelial growth factor receptors, and those basically, to explain it in a layman terminology, cut off the blood supply to the tumor when you give it to them. So they are directed at the tumor and not at the immune system. The mTOR inhibitors, similarly, are target therapies directed at the cell and its machinery, its protein machinery. But again, now it's falling out of favor, and we use less and less. And then the immune checkpoint inhibitors are really the class of agents that have really revolutionized the field and brought immunotherapy back to an age of an era of renaissance. And we'll talk about that. And the last class is the HIF2 alpha inhibitor, and that's the drug belzutifan, which was approved 6 months ago. And I think it's going to have more role in combination with these other agents. So why immunotherapy? Immunotherapy is the backbone of therapy for advanced kidney cancer because the immune system can eradicate tumor cells. And it does that by its adaptability, specificity, and memory. The rationale for immunotherapy in oncology is based here. Expression of tumor antigens that can be recognized by the T cells. And when we talk about immunotherapy, the core of the immune therapy, the soldier of the immune system, if you will, is the T cell. So really, for those soldiers of the immune system to attack, the cancer cell, they have to, those tumor cells have to have a tumor antigen, sort of something that will lend it to be detected, and for that T cell to go and attack it. But also, we know that mutations, both drivers and passengers mutations in genes, occur during tumor development and progression and represent antigens that can be recognized by the immune system. And of course, we have learned that association of tumor-infiltrating lymphocytes, those again, the immune cells, the soldiers of the immune system, when they infiltrate the tumor, something good will happen. And we have, for years recognized that patients whose tumors are infiltrated by these TILs have good prognosis. Now, how can we drive effective T-cell immunity towards the tumor? Think of the immune system as a truck or as a car, and you want to drive it. You want to go and surround the tumor. You want to let the tumor basically give up, or you want to kill it. So basically surrender or kill the tumor. How do we do that? There are multiple ways to modulate the immune system to attack cancer, to kill it, or make it surrender. And you can think of these 4 different ways of modulating the immune system to do that. One is press on the gas pedal. Now, for electric vehicles, you can think of it as an accelerator instead of gas pedal. But that's basically what cytokines, high-dose IL-2, does. And then releasing the brakes, this is represented by immune checkpoint inhibitors. And we'll go over this. A third way is you want to go from place A to B. Obviously, you want accelerator, you want to release the brakes, but you want also to have a steering wheel to direct the therapy to the tumor cells, to where you want to go. But then also, last and not least, you need to clear the traffic. You need to clear the road, and we will talk about that. I will be focusing on the release the brakes, add a steering wheel, and clear the traffic, okay? Because that's really what we've been doing lately. So there are two brakes on the T cells, and these were identified back 30 years ago with CTLA-4. That was the first one. You see it at the bottom there in slide, circled in red, and PD-1. And this work was really pioneered by these two giants, these two scientists who really revolutionized and opened the field of immunology. Immunology, until their work, was really basically a dying field. So you recognize Jim Allison, our own, from MD Anderson, originally from Alice, Texas. And he led the work, first in mice, then, brought it to the human, to the bedside, against odds, because a lot of people were skeptical that his discovery and his application to patients, to the human disease, to patients, would succeed. A lot of people basically said, you're going to be, killing patients. Your therapy is not going to work, and it's going to kill a lot of patients. But he persevered. And for those of you who have not seen the movie Breakthrough, I encourage you to watch that movie. It's an inspiring movie. It tells the story and the achievements, the accomplishments. It's an inspirational, really, story of Jim Allison. And the other scientist who discovered PD-1 on the T cell is Kazuko Honjo from University of Kyoto in Japan. So both of them received the Nobel Prize in Physiology or Medicine in October 2018. And really, we owe it to them for these successes we have now of immunotherapy in patients with cancer in general, not just kidney cancer. So what are the immune checkpoint inhibitors? There are so many, and I didn't want to clutter the slide, but see, here we have what is more relevant, and I put in this purple box the two that are FDA approved for kidney cancer, and basically an antibody against CTLA-4 or ipilimumab, Yervoy, and the other one, the anti-PD-1, and there are two of those. One is Opdivo or nivolumab, and the one is pembrolizumab or Keytruda. And here is a slide that I like to think about, and it's a cartoon of how we look at, results of when we treat patients. So in the y-axis is survival, is patients, number of patients who are surviving over time, which is the bottom, the x-axis. And when you look at a basic, this, control, unfortunately, over time, patients will succumb to their cancer. You give them something, and then, this may be a target agent, and then you may push the curve to the right a little bit, but unfortunately, you're not able to produce a fraction of cure. Here is, where what we like to start, and here is a typical, what we refer to as the immune checkpoint inhibitor. Here is CTLA-4 antibody, ipilimumab. And then when we combine both those two agents, both two antibodies, then this is obviously an inspirational curve to just, inspire us to do the best we can. The idea is you want to, most patients over time, 5 years, 10 years and beyond, to be on this curve or even a flat, just cure everybody. Of course, we have a long way to go here, but this is an inspirational just to let us know how we aim about these things when we give therapies to our patients in the clinic or in the hospital. Now, recently there have been 4 regimens that are approved for the treatment of patients with kidney cancer. A lot of those studies have been in the most common type, like I said, clear cell. And these are the 4 regimens. The first one is nivolumab, ipilimumab, and we led this study in partnership with other academic institutions, as well as Bristol Myers Squibb, the maker of these 2 drugs. And then these other 3, axitinib pembrolizumab, cabozantinib nivolumab, and lenvatinib pembrolizumab. So this is what we call a dual immune checkpoint combination or blockade. You're combining 2 immune drugs. And this is the nivolumab, pembrolizumab. These are the anti-PD-1 antibodies, and these are the oral agents that target patients, and these are the combinations. You notice that all 4 regimens were FDA approved based on improved survival compared to sunitinib, which was the same agent used in all these 4 trials as a control. And I'm going to show you here quickly the results of the one that we led, that I presented these updated results with 8 years median follow-up at a meeting in San Francisco, the ASCO GU, in January this year. And what you can see here, again, remember how we want the curves to be on top. And so the curve on top is the curve of the ipi-nivo, the dual immune checkpoints. And you can see here in the intent to treat population, these are more than 1,000 patients enrolled on this trial. The combination had an 11% improvement in survival at 7.5 years compared to sunitinib, the control arm. When you look at the group of patients who had intermediate poor risk, and again here, we know that patients with kidney cancer, like any cancer, have different, parameters of clinical as well laboratory, and we basically group them as having favorable risk, represented here, or intermediate risk, poor risk, based on these numbers of clinical factors and laboratory factors. And you can see here the improvement for that group with intermediate poor risk is 11%, and here is 9%. So when we look at curves that are called Kaplan-Meier curves with survival or time to event, there is a metric that basically describes the difference in these 2, and that's really referred to as the hazard ratio. The lower the hazard ratio, when it is less than 0.5, the better. But we want it to be below 1. If it's around 1, then basically it doesn't show that your treatment is better than the control arm. So this is really impressive, because over 8+ years, we've seen that we can improve the survival, and we have a plateau, what we call a tail at the end of the curve. So looking at now duration of response, because that's important. And you can see here for patients with intermediate poor risk, it's more than quadruple the duration of a response compared to patients with sunitinib. And even the favorable risk, which the other 3 trials, as well as nivo-ipi, still has not shown conclusively superior. So we see that over time, there is improvement. And here, the duration of response is, even in that favorable risk group, is double the sunitinib. And there are patients who achieve a complete response, and you can see here about 12% of patients achieve a complete response, meaning complete eradication of the tumor. Now, the other trials show improvement in progression-free survival. You can see that in the curve. And what is progression-free survival? It's patients surviving without growing tumor or new tumors appearing. And again, what we do is here, from the time of treatment until the event, you can measure that as PFS, or progression-free survival. So these 3 regimens that I will show you quickly have improved progression-free survival. Tumor shrinkage mostly is the basis for that. But as time goes on, when it comes to OS, these curves meet at the end here. And the same thing here with this regimen of nivolumab plus cabozantinib. You can see here the curves meeting for overall survival. And then the same thing here for this trial. But again, these regimens do benefit patients, and tumor shrinkage is noted, and patients can have better improvement of their symptoms. Now, here are some of the things I look at when comparing this dual immune checkpoint of nivo-ipi versus the IO-TKI, the oral agent plus the anti-PD-1. I think it's fair to say for the nivo-ipi, you have improved survival. It has the longest follow-up compared to the other ones. There is potential to stop treatment, and that's what we call treatment-free survival. For sarcomatoid, which I didn't have a slide to show you here, that's when the tumor is very aggressive. And 10 to 15% of patients with RCC have that in their tumors. It makes the cancer go faster, more aggressive. I tell patients it's like having a turbocharge on your car. For those patients, the data is clear. The nivo-ipi combination, the dual IO combination, produced the most benefit with complete response rate or remission of 23%, 60% overall response rate, and quadruple the survival compared to sunitinib. And the other three regimens, although they help, but they don't have that data. I think there are some downside to giving immune therapy. There are, and Zita will be speaking about, management of these adverse events. Those patients treated with nivo-ipi are at risk of having potential for higher initial immune-related or immune-mediated adverse events. She'll talk about that. And there is a higher progressive disease rate and shorter PFS or overall survival. Now, if you want tumor to shrink and you want it to shrink fast, I think it's fair to say that the IO TKI or an oral agent plus the anti-PD-1, nivolumab or pembrolizumab would be something you can go to. So here is how I approach this in the real world, in the patient, in the clinic with patients when I make a decision about how am I going to treat a patient of mine with clear cell, let's say clear cell RCC and metastasis. So first I ask the question, does the patient have minimal disease, minimal tumor burden, what we refer to as oligometastatic disease? And I'm sure you heard from Dr. Chiateng today and Dr. Rahul Sheth about how we treat those patients. We can treat them with local therapy, stereotactic body radiation or SBRT radiation, surgery or ablation. And that the idea here is to defer drug therapy, to defer systemic therapy for as long as possible, because we want to avoid the toxicity. And because we know very well that patients are going to do well with local therapy, with these things. But if the patient does not have the oligometastatic disease and they have the sarcomatoid, I mentioned already, the treatment of choice is nivo-ipi, and that's what I treat them with. If they don't have sarcomatoid, but I believe that they have one shot at goal, they really need quick improvement of their symptoms because they're really having a huge tumor burden, then I will treat them with a TKI-IO. But if they don't need that rapid response, I go back to, I give them nivo-ipi. Now, if two drugs work well, like as I showed you, those four regimens, would a third drug added benefit improve the outcome? And I think this idea, this concept of more better came from treating leukemia in childhood, adults, germ cell tumor, as well as lymphoma and Hodgkin disease. And so here, this trial looked at adding the oral agent cabozantinib to nivo-ipi. Note here, it's not sunitinib is the control, it's nivo-ipi plus placebo versus nivo-ipi plus the drug cabozantinib. And the primary endpoint of the trial was improving PFS. Well, the study showed improvement of the primary endpoint PFS, but did not show improvement of overall survival, which is more important. Additionally, this regimen, this triple drug regimen, produced 50% toxicity, liver toxicity. And so based on that toxicity and lack of overall survival and the low complete response rate, because patients did not get adequate number of the IPI, I think this regimen did not make it yet to FDA approval. So there is really no triple therapy yet for clear cell RCC, but there are some trials looking at that beyond this other one that I showed you, Cosmic 313. This regimen, this trial, that LightSpark, has completed its accrual of more than 1,600 patients, comparing a triplet regimen of this belzutifan oral agent I mentioned to you that was FDA approved 6 months ago, plus pembrolizumab lenvatinib, versus an anti-CTLA-4 similar to ipilimumab, plus the same regimen, and this is the control. The trial will be, hopefully, results will be available from this trial in the next 2 years, but right now we are awaiting the results, but it has completed accrual. Now, what about doing surgery for those patients who present with a tumor in their kidney and they have metastatic disease? And here is a trial that is looking at whether surgery will improve survival. So patients who present with metastatic disease and primary in situ, they get their treatment with whatever one of those four regimens we spoke about, And then after 12 weeks, they get scans. If they show response or stability of their cancer, then they get randomized, meaning they get assigned to either having surgery then, removing their kidney, followed by continuation of the same treatment that they received upfront, or just continue with the same therapy. So here the question is surgery needed? Will surgery improve survival? We will await the results. This trial is still ongoing, hasn't completed its target accrual. Now, moving forward with immune checkpoint therapies, what are the questions that are facing us? We need to improve patient selection. And that basically identify patients who will most likely respond and exclude patients who will most likely not respond to therapy. If we can do that, then we can spare patients toxicity if we don't believe that they will respond to therapy. But we also need to turn a cold tumor, a desert, into a hot tumor. And again, what is hot is when it's infiltrated. Remember my first line about the TIL, tumor infiltrating lymphocyte. We want to direct the traffic to go for that tumor with these immune cells. And then understanding and managing toxicities, as Zita will speak about, is important. And then we need some newer checkpoint inhibitors. So what about, the newer checkpoint inhibitors? So here is the slide that shows some of the studies that are ongoing with some of the newer checkpoint other than CTLA-4 and PD-1 blockade. And, this is based on work about the resistance mechanism when patients do not respond or respond and then the cancer comes back. What do we find? We find that LAG-3 is overexpressed or increased in these tumors. And based on that, there was a study comparing nivolumab, the anti-PD-1, versus nivolumab plus the drug that blocks this LAG-3. This is the third checkpoint inhibitor that other than the two I mentioned about. And here is the study that was led by MD Anderson, published a few years ago in melanoma, showing the benefit of the combination of this new LAG-3, the new checkpoint inhibitor plus nivolumab compared to nivolumab alone, with doubling of the median PFS. Now, we are going to test this in kidney cancer, and this is the hypothesis. The hypothesis is adding this drug to nivo-ipi will improve because we will be hopefully decreasing T-cell exhaustion and increasing clinical benefit. And this is the schema. Patients will be grouped into two. One will be the triplet with the nivo-ipi plus Dirella versus nivo-ipi alone. And we're going to launch this trial here in the next few months. Now, what about other strategies? Now we're adding a wheel to the car to go to where we need to go to face this tumor. And there are several of these directed. One here is CAR-T from autologous, meaning patient taking cells and engineering them from the patient's own body. And that's called autologous CAR-T, versus off-the-shelf taking allogeneic from healthy donors, engineering those cells and direct them against the tumor cell. And you can see the tumor cell here is in the center with the antigens, and we recognize that those therapies will recognize the tumor cell, basically the clear cell RCC here, through these things on its surface. And then there are several of these. This is the allogeneic CAR-T, and here there are several other ones. One is called, here bispecific antibodies. Here is one that's monoclonal antibody. This is an antibody drug conjugate. It's basically an antibody that will recognize that antigen on the surface of the tumor cell, but it has a payload. It has an explosive. It has chemotherapy that will, once attaches itself to the tumor cells, it will blow it up, or it can give radiation, and that's girentuximab, a new drug that's going to be tested also at MD Anderson here in the next few months. So CAR-T is the next breakthrough, and you heard it from me. Immune checkpoint was the first, but the next wave, the next really breakthrough is going to come with these CAR-T, and these are two trials with CAR-T from healthy donors off the shelf, and we presented these results with these two trials from two different companies. And we have seen some responses. And within this trial from Allogene, Traverse, all patients who had CD70 positive on their tumor cells, which the CAR-T recognizes, had disease control. That means that they had stable disease or a response, either partial or complete. And you can see here the results of one of our patients that Zita and I have taken care of, who had 6 prior lines of therapy. I treat them with everything that is, including trials, including interleukin-2, nivo-ipi, and all the oral agents. including the last one, belzutifan, that was before it was even FDA approved. Unfortunately, he had progressive disease with disease in the spine, lungs, pleura, and other areas. His options were really very limited. There was not much. But I talked to him about participating in the trial, and you can see his cancer. You can see here he had tumor in the lungs, and you can see here after we gave him the CAR T cell therapy, the tumors resolved from his lungs, and he achieved a complete response. So there are now 5 companies with 5 different CAR Ts. 3 of these are allogeneic from healthy donors. They're engineered, and then they're infused in the patient, and 2 are from patient's own. These are what we call autologous, and these are the allogeneic. So stay tuned, hopefully. Now, a picture is worth 1,000 words. I didn't want to finish my talk without really telling you about how we, in partnership with the patient and their caregivers, how we can really turn a challenge in lifetime into a success. And you'll hear about some of these stories later this afternoon from patients who will stand here on this stage and tell you their stories. This is a lady, a patient who came to me about 5.5 years ago with fatigue, cough, shortness of breath, drenching night sweats, weight loss. She was anemic, and she was found to have a mass in her left kidney and tumors in her liver. You can see in the lungs, and also more pictures of the liver disease. And then I gave her nivo-ipi, and you can see the liver metastasis, the cancer in the liver went away, completely resolved, the step in the lungs. Then we proceeded, after we give her those 4 cycles of the 2 drugs, we removed her left kidney, and she didn't have any complications, thankfully. We continued with therapy for 2 years with one of the 2 drugs, nivolumab, and then I saw her 3 days ago in the clinic. She achieved a complete response. She's past 5 years, and hopefully she's cured. And she's working, and she's a functioning member of society. This is an engineer that I saw 6 years ago. He presented with a big tumor in his right arm. He couldn't raise his arm. He had tremendous pain. And as you can see here, he had tumors in his lungs, those tumors here. And this is his right arm and this tumor. So after we biopsied it, we found that he had clear cell. We treated him with the same regimen, 4 cycles of nivo-ipi. And you can see here his response. This is the tumor in the lungs, went away. And you can see the mass in the kidney. We proceeded, we removed his left kidney, and we resected this right proximal humerus. And there was no viable cancer in the arm, in the bone in the arm, in the right humerus. And there was less than 20% viable cancer in the left kidney when we removed it. This is a lady who came 9 years ago after the late Dr. Chris Wood referred her to me after he removed her kidney and her right kidney. She had disease in the lungs, disease in the liver, and in the lymph nodes. I enrolled her. This is the other 2 patients I just told you about were treated with standard of care because the FDA had approved this regimen we pioneered. This lady came to me before the trial was launched, before the FDA approval of any combination of immune checkpoint inhibitor. So she came to me, she said, I'd like you to treat me because you treated a patient in Tennessee with this immune drug. It was nivolumab alone on a different trial, and he done so well. I would like you to treat me. I said, well, we have this trial. You have a 50-50 chance to go either on the immune therapy or the sunitinib. I hope you will get to randomize or be randomized to the immune. She did get the immune therapy. She got assigned the treatment with the 2 drugs. And after the first cycle, she had inflammation of the thyroid. After the second cycle, she had inflammation of the lungs. Again, Zita will speak about these things. And I treated the inflammation in the lungs and the thyroid, and then gave her a 3rd cycle. Well, she had toxicity in the liver. We stopped there. We took her off protocol after those 3 cycles. But you could see that her liver metastasis went away. Her lung metastasis went away. She achieved complete response. 9 weeks it took to give her 9 years. 9 weeks of therapy, and she has 9 weeks now survival. So 9 weeks of therapy. We stopped. That's the treatment-free survival we talked about. That's what patients want. Patients want to be treated and not continue treatment forever. They want to be treated, achieve a complete response, be cured, and not have to take any more therapy. This is what she achieved in 9 weeks, 9 years, and she's alive. I saw her 3 weeks ago in the clinic, and she's doing great. She's cured, I hope she will live a long life. And I hope her success story will be also the success story of people who are in this room and people who will be watching. Now, microbiome, it's important. And I know I'm going beyond my allotted time. And thank you, Matt, for enduring with me. But it's important. There are other things than drugs that we can do for our patients to help them. And we'll talk about what can we do. Remember the car, the gas pedal, the brakes, and then we need to clear the traffic. So we have recognized that the gut microbiome modulates the response to immune therapy in patients with melanoma and cancer. And these are two seminal studies published in a very prestigious journal, medical journal Science. This one here was from MD Anderson in melanoma. This was from France. And there were follow-up studies looking at what can we do to modulate the immune system if we recognize the gut, what we eat. And so what's in our gut could affect positively or negatively our response to immune therapy. Well, they found that if you give fecal microbiota in the rectum, you will improve outcome. And these are studies that showed that. What about diet? This is a study, again, MD Anderson, led by MD Anderson, Dr. Wargo and Dr. McQuaid, and published recently in Science, where they looked at patients who were given high fiber diet versus those who had insufficient or low fiber diet. And you can see here, the patients who got the high fiber diet had a better outcome. And you remember, when we look at these curves, what we call, Kaplan-Meier curves, we want to see a flat line. We want to see a shoulder, a tail at the end of the curve. And we want it to be as high as possible above the axis. And we want to see as big of a gap between the two treatment arms. So this, again, indicates that high fiber diet can improve, can enhance, can modulate response to immune therapy. What about fasting? So this is a study that was started by a colleague of mine at Moffitt, and now it's being continued at Duke. And this is in patients with head and neck cancer. What's TRE? Time-restricted eating. It's basically making patients fast for 14 hours. So patients fasted from 6 p.m. till the next morning, 14 hours. And those were patients with head and neck cancer. And they were treated with pembrolizumab, the anti-PD-1. And when you look at those patients here, this is the progression-free survival in blue or turquoise are patients who were treated with pembrolizumab, plus they were fasting 14 hours, and those patients here did not fast 14 hours. And here is the survival. So both progression-free survival and overall survival was superior in patients who fasted 14 hours. So basically, this work was really based on preclinical mouse experiments, mouse studies that showed mice that were had restricted feeding 14 hours, had tumor shrinkage, and lived longer than mice that were not treated with the treatment-restricted feeding. Okay, there are some other trials now looking at can we give something by mouth? This is a CBM, a live bacterial product containing Clostridium botulicum. And these are two pilot studies from the same institution looking at Nivo-Ipi plus this CBM versus Nivo-Ipi alone. And there was improvement in progression-free survival and response rate. This is a similar trial with a different control regimen, Nivo-Cabo. Again, these are the regimens that are FDA approved, as I showed you. And again, adding this CBM 588 showed improvement in PFS. So these are pilot studies. Obviously, the limitations, small number of patients, and the control arm didn't perform as well as we had hoped. So now there is a phase 3 trial that's looking to really validate this in a large number of patients. What about something else you can take other than the CBM 588? This is a trial where it's basically given patients camu, which is a fruit from South America that tastes good and is less filling, I heard. And patients are randomized to receiving the immune checkpoint Nivo-Ipi plus this fruit versus Nivo-Ipi. And we'll see if this trial will show the results that we hope to see. Now, what about this association between pre-treatment emotional distress and immune checkpoint inhibitor response to non-small cell lung cancer. This is a Chinese study of 227 patients with lung cancer, non-small lung cancer, and investigators gave those patients prospectively tools to assess their emotional distress. High anxiety and depression score high, and that's not good, versus those who didn't have this problem. And they gave them this at baseline and gave them this on follow-up, and they looked at their outcome treated with chemotherapy and immune therapy. And here are the results. For progression-free survival and response rate, you can see that the group that had low or no emotional distress in blue did better. And the response rate, you could see it here, 46% versus 62% for the top curve. Looking at survival, again, the improvement is in favor of patients who had no or low emotional distress. And you can see here the 2-year probability of OS was 46.5% for those patients with high emotional distress, and it was 64.9% 2-year overall survival probability for patients who had low emotional distress. So a look to the future of RCC therapy. I think pushing new frontiers and boundaries for discovery. We can't make progress without research, and that has to be obviously, all of us should embrace, discovery and research, and we need to leverage technological advances to ultimately break the barriers of cure. I hope in my lifetime that we will achieve cure for all patients. But in the meantime, I think there are challenges that remain. Identifying biomarkers of response and resistance, and of course, we want to reduce toxicity. Goals of care, in my opinion, should be we need to produce durable complete remissions to lead to cure. We need to prolong survival. We need to improve quality of life. We need to minimize adverse events, and we need to reduce duration of therapy. Remember the patient I told you, 9 weeks and 9 years now life. Reduce cost. Finish it with this important study. It's a survey in more than 1,000 patients with RCC. About 40% of them had metastatic disease. The question was asked, okay, and you can see it here, chance of what are the most important questions for you as patients, and these were the questions. Chance of eliminating all evidence of disease. I want to achieve a complete response. Durability, improved quality of life, rapid reduction of tumors, ability to go off therapy, this treatment-free survival, low risk of toxicity, the reduction of tumor symptoms, and low cost. And you can see here to the left, this was not important, least important, and you can see low cost. Most patients didn't really care about this cost. But again, you can see here from top to bottom, the priorities for patients. Most important is to achieve a complete response. I want to finish by giving a tribute to my colleague and friend for 20 years, the late Dr. Chris Wood. Dr. Chris Wood is a giant in the field, and he's so missed. He's sorely missed by me and by everybody at MD Anderson and his patients and colleagues. I know Matt shares this with me, and we would be here if it wasn't for Chris. Chris started in 2005, leading patient conference for patients with kidney cancer and their caregivers, their friends, their families. And I had the opportunity, the privilege and honor to join him since 2005 and we haven't done it. This is the first year we're doing it since he passed away, and he is missed. And I want to thank you very much for your attention and for your trust and for, again, reminding us of the urgency of our work and inspiring us to keep the fight. Thank you.